So sorry about that, guys. I thought we had the technical difficulties figured out, but apparently we didn't. Um, like Laura was saying, my name is Rick Knecht. For those of you who don't know me or haven't worked with me before, I trained in emergency medicine and graduated last year. So some of my training is still pretty fresh. And I do moonlight while I'm in fellowship in an emergency room down in the Puyallup area. So I'm still working in the emergency room part-time. So kind of the kind of overview of my talk is kind of just really what I started thinking about both spheres, because I'm going to keep working in both spheres, is kind of how to meld together what an emergency is, and then kind of the things I've been thinking about in terms of how do I take my emergency room training and formulate this kind of understanding of what a palliative emergency is and how we kind of formulate that. And then we'll talk about a few cases that I think really highlight some of the questions I've been having about how we do palliative medicine in and out of the emergency department, and how kind of my experience doing both spheres of practice has kind of influenced one another. I had, and then those cases kind of brought up a lot of questions and some take-home points for me. And then I'm hoping to have a discussion, but that may be cut short just because in the interest of time. So again, what is a palliative emergency? And I think that raises a lot of different questions. I think that if I asked everybody in the room or on the meeting what they felt a palliative emergency was, they may give me a bunch of different answers, and some things came to mind. So, I spent 4 years training in Los Angeles, and what is an emergency, or what is an emergency when we think of typical care in the kind of the more medical treatment sphere, and that's essentially an immediate threat to life and limb, requiring a prompt or aggressive treatment. And this is what I spent 4 years training to do. And I think that, regardless of how I move forward in my care for patients in any capacity, I think that I'll kind of always look at things like this, even though I'm constantly learning new ways of looking at what might be an emergent reason for seeing patients. So, how does that feed into what a palliative emergency is? And I came up with this sort of working definition. And that for kind of briefness sake, it's any situation, acute status change or complication that arises in a patient who is undergoing treatment for chronic health conditions, terminal conditions, or at the extremes of age or ability or kind of lifespan. I think one of the things I've been thinking about is they don't necessarily have to be an quote unquote palliative patient for them to be experiencing a palliative emergency. And I'll go through a list of things I experienced in the emergency department over the last couple of years that have kind of led me to believe that and kind of feel that we can be providing palliative care to patients, even though they're not typically what we would consider palliative patients. Nobody placed a consult on them. And, I wear a lot of hats in the emergency department. So I think, I put on the palliative hat, for 4 years in training and throughout this year, as I've taken some of the skills I've learned in palliative training in the emergency department. And I think that there's a lot of overlap. So I think there's a lot of overlap between emergency care and what we consider to be an emergency and what we would consider to be a palliative emergency. I think there's a lot of overlap there. So when I think about a palliative emergency, I think about patients having either a psychologic or physiologic crisis. Those could be acute symptom crises, things like acute respiratory distress, acute hemorrhage, altered mental status, things like terminal delirium. And it's in a patient with a serious illness or life-limiting illness. And this is where our training comes in. It's in big time is, for those patients that are there's a decision context, whether that be acute symptom management or goals of care decisions. So, in the last year or the last couple of years in the emergency department, I started to aggregate a list of things that I thought qualified patients for me providing some sort of palliative care. And there's a long list here. Realizing patients that don't have an understanding of the disease. Realizing patients, coding patients with the questionable goals of care or DNR status. We do that all the time in the emergency department. We would terminally extubate patients in the emergency department. I still do. We would often stop a code or have the length of how long we coded patients informed by, Things like age, if someone's a 99 and it's not going well, we tend not to go, long time coding patients in the emergency department. I often frame my discussions with family or another team member under the lens of comfort instead of long-term outcomes for patients in the emergency department. So you can kind of see, and it was just in the interest of time, I won't belabor the point, but you can kind of see how these things kind of influence care in the emergency department, and not just, when I'm here Monday through Friday and as a palliative care fellow. But, in the last year, I've also started to look at patients and how are some of the things that we're doing in the palliative care sphere sort of seen as an emergency. And I think that, there's some common themes. So in the last year, I've realized that patients have no understanding of their prognosis of disease trajectory at very critical time points in their care. I've discovered the discordance between patient and family goals when big decisions are needed to be made. I've had undergoing burdensome treatments that doesn't match their values for various reasons, and again, at maybe key time points in their care. I've had patients nearing the end of their life that have never had a goals of care discussion before, and time is very short, kind of pushing us more into that emergency sphere. And I've had surrogate decision makers that seem sort of inconsistent, between wishes between family and surrogate decision makers. And then, we've had a lot of patients that have had acute or unexpected symptoms, or had symptoms that are really difficult to control. So it kind of made me think of like this concept of a golden hour. I mean, I think you could really boil down a good proportion of my training in emergency medicine was really how do we provide care during that golden hour? And really what that boils down to is that just an acute intervention meant to save life or limb, many of which are time sensitive, that unless I act now, the patient's not going to do well. And I wonder if there is a golden hour in palliative care with a different focus, though. In palliative care, our focus really is like golden hour. And a golden hour, if we don't intervene or we don't intervene quickly, really can shape how someone lives or dies in a pretty critical moment. So that's just kind of a primer for why I'm doing the talk and some of the thoughts I've been having. We'll talk about a few clinical cases. So case one, and this is a case I had as an intern in the emergency department. I had a 68-year-old female come in from home hospice, and she had stage 4 metastatic cholangiocarcinoma and obstructive ascites. She came in off of hospice with her son and daughter caring for her. And she was coming in because she was hoping to get a paracentesis. And this is kind of a visual representation of what her abdomen looked like. She had very tense ascites, seemed very uncomfortable. She was complaining of diffuse abdominal pain and significant shortness of breath as a kind of, I think, from a mass effect from her very distended abdomen. But she didn't look well. She was very dyspneic. She was sort of altered, and she was pale. And the patient's son and daughter brought her in kind of as a cry for help because it sounded like things were not going well at home. So immediate considerations, for this patient and walking in as an intern, not being palliative trained, the patient's on hospice, how does my care in the emergency department kind of affect their long-term care? How do I go about eliciting sort of goals of care in the short term? And there are reasons for that, and I think we'll talk about the next slide, because, I'm happy to offer a paracentesis to those that can benefit from one. And, when is a procedure appropriate for a patient on hospice? From a kind of philosophical standpoint and from a granular standpoint in terms of who pays for that. Does that, create problems for the patient? And then, could we just do pain meds and treat symptoms? So in the interest of time, I won't do a polling of the group just because I think we're running a tad behind. But here's what I did. Had a pretty frank discussion with the family members because, while she looked uncomfortable, and I'm pretty sure I can make her look immediately feel better with a moderate to large volume paracentesis, I'm worried she's too ill to do a procedure. I can't confirm that. I don't have a trajectory for, kind of her her symptomatology and how she looks clinically. Maybe she's sort of always a little altered. Maybe that's a new thing. But I decided to get labs. And, again, I think That could have been a, looking back on it, it could have been a good or a bad decision, but honestly, they looked terrible. I think her creatinine was like 9. Her BUN was crazy high. Her INR was like, I think, 10, and she had like 1 platelet. So putting that all together sort of made me think like maybe she might be quite close to the active dying phase. So I kind of broke part of this as late 2021. So I kind of broke protocol and brought all the family members back from the waiting room, because during COVID we weren't letting more than 1 or 2 family members come back. And I said, guys, I'm really worried that if I do a paracentesis, she may end up passing away. I don't know if she has a physiologic reserve to go through that procedure, and I wonder if the benefits outweigh the risks outweigh the benefits. And unsurprisingly, in the emergency department, I didn't have a lot of time to stand and spend that time really exploring that option with them. I had to say, I think in fact a trauma came in, and I had to say, like, here, I'm going to give her some pain medicine. Why don't you guys think about it, and I'll be back. So she, after pain medications, she started to clinically deteriorate. In fact, I was in the trauma bay and someone came and found me and said, "Hey, Rick, your patient in 13 doesn't look so great. I think she might be, about to code." And I had to say, "Well, we're not coding her. Please don't pull the crash cart over, but let me come see her." And she died about an hour later in the emergency department. But so this case kind of highlights some questions for me. What about procedures in palliative care? Should we be offering procedures or advocating for procedures for our patients? And I know that there's a number of drawbacks and benefits of this, and I know that it depends on where the patient is on a continuum. I sort of wonder about this case. I don't know that it would have made a big change in overall of our symptoms at the end of life. I think she was very close to passing away when she got to the emergency department. But I sort of wonder, should that something like a Pleurex catheter or something that would have been more hospice oriented been offered to her. So I wondered if this has ever been studied or if there have been any consensus or opinions on this. And I found this paper published in 2017 by a person named Buss, and it's titled "The Intersection of Palliative Care and Interventional Radiology." It's not a research study; it's more of a narrative review and expert consensus. But their argument in the paper is that interventional procedures should be offered in the palliative care hospice space more readily and earlier when thought to provide immediate symptom relief, when they're minimally burdensome. And I would argue that things like a thoracentesis or paracentesis are pretty minimally burdensome. They've been done at bedside. And they really align with patient goals. They also noted that many providers, including palliative care providers, underutilize procedures as comfort-focused interventions. And they noted that there seemed to be sort of a misconception or even a stigma that when we're transitioning to comfort-focused care or, in quote-unquote palliative care, that procedures are seen as anti-palliative care. So just some kind of added context for this kind of thought. So my takeaway, should we be offering procedures that have potential to immediately alleviate patients' symptoms? And I've been reflecting on that over the course of the year when I think about this case. And, I think our reflex is to generally, especially in the comfort care focused model, to offer more of a symptom control through medications rather than considering a paracentesis or a thoracentesis, for example. I think I've had several patients more with pleural effusions that we treat symptomatically rather than offering something at the end of life or during the comfort care when we transition to comfort care. So I'm sort of wondering, should we be offering that a little more? And I don't have a great answer for that, obviously. My second thought is, for those comfortable, for myself, I'm trained to have procedural skills that could lend to this, or people that are surgery trained or critical care trained. Is there space for those things being part of our repertoire, or things that when we're cross-trained in both palliative care and some of our procedural specialty? Is there a role for that, and should we be advocating to be credentialed to do things like that at bedside? And I know that might be a little bit of a mess. Again, I'm not advocating for that. It's just a thought I had. And then there's a case to be made for patients to go home, or we should have more of a dialogue for patients to go home with things like a Pleurex catheter for a pleural effusion or malignant ascites to kind of help with symptoms at home. So this was kind of takeaways and questions I had that I've been thinking about this year as I think about this case I had several years ago. Um, On to case two. So case two is a 62-year-old male with a history of cirrhosis. We knew this gentleman pretty well. He came in quite often to our county hospital with lots of complications due to his end-stage cirrhosis. He was still drinking and thusly not a transplant candidate, although that had been discussed multiple times. Through multiple admissions, we kind of already knew this after reviewing his case multiple times in the emergency department. He had kind of ongoing and active goals of care discussions with our palliative care service at our county hospital, and hospice had kind of been brought up with the patient. He had multiple recent admissions for hepatic encephalopathy and GI bleeds, some pretty significant. And that year had a prolonged admission for a pretty bad pneumonitis, almost ARDS level, for an aspiration of hematemesis. So he came in one night with active high volume hematemesis, but was surprisingly stable, as he tended to be, even though he would hemorrhage. He had like surprising physiologic reserve, and he and his wife, I think, he was pretty lucid, even though he was, critically ill. And he and his wife had already kind of been primed through the palliative care service to have some of these goals of care discussions. And so we started having some in the emergency department. But clearly, when someone's vomiting blood, they're at high risk for clinical deterioration very quickly, and there wasn't a lot of time. So as we talked and in between periods of vomiting, he and his wife sort of elected for more of a comfort focused model. Like, he didn't want to have another GS scope. He didn't want to spend weeks in the hospital. And he was sort of tired of coming into the hospital all the time. And so we talked about that. Okay, well, what does that sort of look like? But one of the things he kept saying to me is, I don't want to choke to death on blood. So again, I won't pull the group, just out of a matter of time. But here's what I did. So we talked about sedation and symptom control, but he just kept saying, well, if I'm going to be sedated and I'm going to continue to probably vomit, I don't want to choke to death, which led to kind of an opening discussion about intubation as a way to prevent him from aspirating his own, bloody vomit. And ultimately, he elected to, that intubation sort of was a comfort focused thing for him because that's not how he wanted to die. So I waited for a period of stability, and I intubated him using kind of an awakened ketamine approach. And just kind of for everyone's information, that's just you give patients a sedative that doesn't impact their ability to breathe, kind of a large dose of that, and they're still breathing, and you just intubate them without a paralytic. And so that's how I approached that. We sedated with some midazolam instead of propofol, just to keep his blood pressure from not tanking, and then we placed an NG tube. And then I admitted him to the ICU, which ended up kind of being an interesting discussion, because they're like, well, you're telling me he doesn't want all of these heroic measures, and now he's DNR, and he doesn't want a scope, and he doesn't want to go through all this again, but you intubated him. And I was like, well, yeah, because he kept telling me he didn't want to die of aspirating his own vomit. And he had been through that before, that previous year, with the long admission to the hospital. So sort of my dilemma, and it's thinking about this case as I've gone through the last year, when, if ever, are high burden interventions such as an intubation appropriate for a comfort focused patient? And again, I don't have a great answer to that question, but in this case, I sort of think it fit. Should we always be seeing intubation as a way to prolong life, or is there a case to be made for preventing suffering? And I sort of think about some of the patients that I've palliated, both in the emergency department and during, we've done palliative care, comfort care for people with, during this last year, where we've done it for people who have significant shortness of breath. I think that's one of the things I was like, well, maybe, if somebody's really, really struggling, that could be seen as a comfort measure. And I don't know that that's, again, I'm not advocating for that. It's just one of the thoughts I've been having. And is this even a feasible approach? With this patient, should I have not offered an intubation in order to keep him from aspirating? I don't know. But in this case, and I think that it really aligned with his goals of not dying a certain way. I think my takeaway is sometimes aggressive measures can be a bridge to comfort, not seen as an escalation of care. Um, and although I think that it's something like intubation or a heroic measure is probably rarely appropriate. I would say that it's not never appropriate. Uh, and it kind of evidenced by, I think, this guy's clinical outcome. He kept clinically deteriorating, but through further goals of care sessions in the ICU, they did kind of a balanced, non-aggressive resuscitation to keep him alive until family members could get there. And then they stopped, kind of the resuscitative efforts in the ICU, and he died about a day later, still intubated. And he didn't die of aspiration, which is sort of his goal. So interesting kind of case for him. Case three, I was a 71-year-old male. This is, again, a guy had a fourth-year residency, I believe. Came in currently on hospice. He had bilateral nephrostomy tubes, and one of them got caught in his bed and got tugged. They came in to make sure that it hadn't been dislodged. He had a lot of pain that had developed there and was wanting to make sure that it hadn't come out. But he was also kind of in a pain crisis, and talking to his sister, who was his caregiver, with whom he was living, sounded like over the last couple of days his pain had not been very well controlled, despite trying to work with the hospice agency. So, kind of the few things that were kind of bothering this guy in the moment. So for me, a non-palliative care trained fourth-year emergency medicine resident, kind of some immediate questions came up. What, if anything, can I do to screw up this hospice for this guy? And as a novice, those questions are prescient. And frankly, his sister had worries about that too. I mean, should we be bringing him to the emergency department? Will they kick us off hospice? All these other questions she was having for me as I kind of got to know them. The other question I sort of had was, what will hospice cover versus Medicare or insurance cover if I order certain labs or testing? Will there be a conflict if I order imaging? If I get a CT scan to make sure that this nephrostomy tube is still in place, is there a conflict between, his insurance company or his hospice agency? Will that be seen as restorative care? And will I screw something up for this patient? And then if it is out and it is related to his cancer, and because his cancer is causing this obstruction, what if he needs to be admitted for a procedure? What if they have to replace this nephrostomy tube? How does that factor into this kind of granular milieu of concerns surrounding this hospice patient who came to the emergency for emergency care? And the other big thing was his pain adequately controlled at home? Did he need to be admitted because he was in a place where his just pain wasn't really well controlled at home? And would he benefit from an admission? So taking a step back and just thinking about how, I've come to understand a little bit better how hospice is delivered outside the hospital and how that affects people's care, both in and outside the hospital. Patients can come to the ED for emergency care, and that doesn't necessarily mean anything for the patient. So that's the first kind of thing I've learned. Patients are not automatically disenrolled from hospice if they come to the emergency room or for emergency care, and they absolutely can come to care. And as far as I understand, they can even have their PCP involved for things like that aren't related to their terminal illness. And their Medicare insurance should cover that. One thing that I kind of this is where it gets a little more gray, is things like related costs, or those that can be directly tied to the terminal diagnosis. And so those are the things just to keep in mind for me, at least, when I'm working in the emergency department, and things like, dyspnea, pain, pleural effusions, terminal delirium. Maybe they're tied directly to the patient's lung cancer, for example. And maybe that could be seen as related care that may not be covered for the patient if they come to the emergency room for those reasons. It's something maybe a little bit more a gray area for the patient. And then unrelated costs would be, of course, if the patient came with like a fracture or a fall, or a UTI not directly to their medical or terminal condition. Um, the patients won't lose their hospice status unless they seek care to their related to terminal condition. And what I mean by that is something like electing for more aggressive treatment for their uh, uh, terminal condition, wanting a second opinion, and re-engaging with treatment options on that terminal condition, or further treatment for that worsening or terminal condition. And then patients can still be admitted to the hospital and not lose their hospice benefit. For pain control, for specifically, and it hasn't related to this patient. If something cannot be feasibly provided, if the pain control cannot be feasibly provided in another setting, home hospice can be often transitioned to GIP if they qualify. And then really the big thing that I learned and was super helpful for me as both a practicing palliative care doc and an ER doc is hospice agencies have social workers and nurses that are on 24/7, and you should call them, and you should call them early. So, some hospice myths versus in the ED, hospice and the ED myths versus facts. So myth, patients going in the emergency room. If the myth is if you go to the emergency room to seek care, you're no longer on hospice, and this was his sister's worry that if she left the home that they would lose their hospice status. And going to the ED doesn't automatically revoke or discharge you from hospice. And I had to really reiterate that with the daughter or the sister, and really train myself that was the case, because I was also worried about this in this case. There's also kind of a myth that the hospice can unenroll the patient if they go to the hospital. And then the only reason that the patient gets disenrolled is if the family or the patient and the representative revoke their status, or if there's a CMS, is if there's another problem with the CMS specific regulatory reasons why a patient might be disenrolled from hospice. Third myth, hospital admission and hospice are mutually exclusive. That's not necessarily true, especially if it's for things like symptom management and the patient can be re-enrolled on GIP. And then the third myth, which is also very reassuring, is once revoked, hospice is lost for good. No, patients often come and go from hospice all the time. They can through benefit periods and personal desires, can decide that they don't want to do it, and they can requalify later. So, for this guy, what I ended up doing for him is just had a long, frank discussion at the bedside about treatment options. Frankly, his tube did not look like it was out, and it was still draining. And I offered him imaging just to be sure. And after some reassurance and some pain control, they elected to go home on symptomatic control. But I did this all through under the direction of the hospice agency. They were super helpful and very approachable. So the outcome for the patient, he ended up getting symptomatic control, felt better, and wanted to try going back home. Again, his tube seemed intact. It looked like it was all draining. And then, I was able to help coordinate an early visit in the morning from the hospice agency to see if they could do a symptomatic management check. Which they were very appreciative. So my takeaway with this case, we, or maybe just me, working in the emergency department, working outside the, palliative care and inpatient sphere, should have a better understanding of the nuances the patients can experience who, when they come out to the hospital while on hospice. We in the palliative care sphere may be consulted to answer those questions from the emergency department. So I think it bears kind of, at least it's a reminder to me that I should be better at understanding kind of the rules and regulations and kind of the more granular details, again, that a patient may be experiencing or maybe worried about, or the providers might be worried about. And it's been clear to me, both talking to some of the other emergency providers that I worked with, both in Los Angeles and here, and have the other cases I've had, that not all providers are going to know how to handle such cases, and there's going to be a lot of stress and worry from both patients and families, and the other providers that they might screw something up. And then there is a lot of stigma and myth and worry associated with hospice patients coming in for care. And the biggest thing was, and it was, an underutilized tool, I think a lot of times the hospice agency itself can be a good sounding board and for a lot of this stuff. Case 4, in our last case, I had one night, I think it's again a 4th year, 80-year-old female who came in with a long history of dementia and CHF. Seemingly poor baseline quality of life. She was already starting to develop a little bit of dysphagia and some mobility issues. Came in with progressive shortness of breath and eventual decompensation at home, requiring them to call an ambulance. She arrived at us, with O2 sats in the 80s and what appeared to be acute cardiogenic shock. And her daughter showed up with her, and it was like, I want everything done. Please intervene. And as I'm talking to the daughter and trying to getting to know the patient a little bit, and while we're doing things to kind of temporize some of the obvious distress in the patient, someone says to me, "Hey, Rick, she's not looking so good." And I look over, and indeed, she was very pale and didn't have a pulse. So she proceeded to arrest. And we initiated a code and a CPR really quickly. But despite this, we continued resuscitative efforts for a little while, and I think it was it was me that stepped away to kind of talk to the daughter, just let her, hey, things aren't going so well. Us to keep it continuing. She said, yes, please keep doing everything you're doing. I think we ended up continuing CPR for about half an hour at her request. We couldn't get a return of spontaneous circulation, and I decided to hand off the management of the code to co-resident, and I decided to sit down with this daughter to kind of have a break and do a goals of care discussion. So in this setting, I sat down and shared my worry that after this long, especially in a patient with a bad heart, the likelihood of a meaningful recovery, meaning getting back to some semblance of her previous function, was essentially zero. I kind of tried to tie that back to the progressive loss of function and early, already poor quality of life, as she's been experiencing two serious organ dysfunctions in her dementia and her progressively worsening CHF. I sort of shared that we were running out of options. I tried to provide as much as emotional support because I think her daughter was really, really still hoping for us to intervene heroically. And I sort of recommended that we stop. Which brings me what we've been taught over the last year with sort of how in an ideal setting, when we're given the time, we start to build this house model, right? Where I can establish a relationship with the patient. And the focus of this kind of commentary is that I don't always have this time to establish rapport and build that framework of a foundation for the patient. So typically I'm faced with this. And I would say that I'm probably building more of a twig house on sand than I am, building this big house model that I've been trained to focus on this year. So, what do I do with that? And what have I been trained to do in the emergency department? It's sort of a shorter framework. And I was trained to use this thing called a UVR framework. And I think it was just a thing that one of our attendings came up with the residency. I don't know if it's a published thing, but it's something it's something that's easy to remember. And it's just this idea of it's called again the UVR framework. It stands for understand, explore values, and make a recommendation. So in the understand, obviously it's quickly trying to figure out what the patient or the surrogate understand about what's happening with their care, what the new kind of headline or change has been, and then pretty quickly sharing our understanding of the case and why we're having to have the goals of care discussion. And unsurprisingly, a lot of times in the emergency department, if I'm pressed for time, especially in cases like this woman's, I don't always ask permission to have a difficult conversation. I sort of just lead with, I'm worried and I need to have a conversation with you. Then it's, trying to quickly go through a values exploration and try to link some decision making to values, which can be a little bit tough to elicit in a short term, especially when you're asking somebody to make a rapid decision under duress. But the biggest take home point is here, I think, is that I trying to focus on trying to make a recommendation rather than giving people options and letting them think about it, because often in the emergency department I don't have time. Um, so from the kind of the way I approach this is uh, it doesn't need to be a perfect conversation. And the way I have to sort of think about that is that as long as it's directionally correct and I'm starting to get to the point where I'm understanding the goals of care in the acute phase, I'd rather have that than be comprehensive. And I always try to lean towards making a recommendation, and if I can link that to the patient or surrogate's values as best I can, I tend to do that. But again, times can often be short, and we're making really snap decisions under duress for either the patient or the family members. I tend to focus on the immediate decision. In this case, do we keep coding? In other cases, would it need to intubate? Should I admit this patient to the ICU? But I could see how in the uh, in sort of a palliative emergency, how a framework of this might be useful. Sometimes we're called to bedside because of acute changes in patient status, or even consulted when time is actually very, really short. And we do see patients that are undergoing some sort of active goals of care discussion in an unideal situation sometimes. And then I think it's also important to just kind of normalize uncertainty, even though that can kind of put layers of complexity into the whole discussion. So the reason I bring all this up is just I think as I've been thinking about my training as it informs how I practice palliative care, and my palliative care training, how that informs some of how I practice in the emergency department. I think this is a good tool to have. There's kind of this serious illness discussion in a short amount of time, and under duress tool. And I've adopted this tool, but again, I think if we have time, I'm wondering if other people have other tools. But I think it's important to recognize certain important frame shifts. I don't always ask permission to have a tough discussion, especially when time is a valuable commodity. Again, I've said this 3 times. Maybe I shouldn't have. I try to make a recommendation, and the reason for that is I think it avoids some ambiguity, and it alleviates some of the burden of decision making from people who are kind of shocked. And again, that recommendation is always up for discussion. And I try to limit these discussions to 5 or 10 minutes at the most, or even less, especially again in cases with this lady that came in and essentially coded immediately. This is just a quick primer to just say that I think if you've done consults with me at the beginning of the year, you might have noticed that my approach was sort of goal directed, and I think it's informed by my emergency medicine training and kind of how we wear a palliative hat in various capacities in the emergency department, and we're kind of always forced to do that. But here's some of the things that I've learned this year that have really informed my care in the emergency department, which I think have had a really great benefit. And one of those is that I always sit with my patients now. I used to do a lot of hovering over gurneys or leaning on gurneys or, leaning against a piece of equipment and talking to patients. But I always try and find the stool and pull it over and talk to patients now, which has had a marked and an almost seismic shift in how I, relate to patients and how our interactions go. I'm often finding that even if I have to tell the patient, I don't know what's going on with your abdominal pain, but I did this workup, they're a lot more receptive to it when I've taken the time to sit with them every time I talk to them. I'm much better using those nurse statements. I had a lady the other day who passed out at home, and I, just simply said to her, she was, seemed a little embarrassed. I said, "Oh, that sounds really embarrassing. I'm sorry that happened." And it was like she just opened up, and you could tell that if I hadn't had that, training about how to really establish rapport really quickly with patients, we might have not have had a very good relationship right off the bat. And so that's all just to say that I have a better understanding of how to build rapport rapidly. So this is sort of how palliative training is influencing my care outside the emergency department. Um, so, again, just a summary of some of those takeaways and questions that I got from each case. Case one, uh, perhaps we should consider more interventional management of symptoms at the end of life, even for patients who are on comfort care. And again, I don't have a great way to advocate for that, and I know it's complex. Um, are there instances where heroic measures can be seen as comfort-focused interventions? And I would argue that for the gentleman I talked about in this talk, it was definitely the case. Um, that I think this reflecting on some of the patients I've had coming through the emergency department on hospice. I think it's important for at least me to have a good working understanding of the nuances of hospice to guide providers and families. And I'm reminded of that pretty constantly, both in palliative care work and in the emergency department. And I think it's important to have a real framework for acute illness and acute decompensation, serious illness talks, and so it's easy to wield in those moments, which is kind of my take home from the fourth case. Yeah, I don't know. Where am I doing? I got 4 minutes. Uh, Anybody? Let me stop sharing. Anybody have anything to add? Or I was hoping to engender some sort of um, discussion with this because it's some interesting cases that I've had, but I don't know if anybody had some immediate thoughts based on um, kind of some of my take homes from those four cases. And sorry if I went really fast. I was just trying to get done in a respectable amount of time. Yeah, Chris.
Hey, my name's Chris. I am also EM trained,
Oh, great.
neurocritical care attending here, and I do neuropalliative care research with Claire Kreutzfeldt. So a little bit of a blend of what you're doing. And just one thing I guess I would comment on is your kind of approach to this rapid, quick, the kind of serious illness conversation. And I think similar to how sometimes our role in emergency medicine is to stabilize and get the patient upstairs, I think it's also somewhat similar in a palliative care sense too, that perhaps more than having the patients make a decision or families make a decision, like getting them thinking about the patient's values and goals and how that relates to their new diagnosis or worsening diagnosis may be a sense of like stabilizing the palliative care
Yeah,
emergency, to use your analogy. So I think there are certainly times where your approach may be fitting, but that's just another thing I would consider, that just like you intubated the patient so that he wouldn't have the death that he didn't want. Sometimes intubating somebody to allow for more in-depth conversations later may also be a correct approach, or starting pressors, whatever the emergency may be. So it's just something to consider.
yeah. And I think if you really, I think if I zoom out on that case particularly, if you reframe it rather than a goals of care discussion, but more of a modified care, uh, you know, pathway where we're giving him more time and honoring goals of care. It's not like an earth shattering case. I mean, we do this all the time, right? I think we do kind of a balanced recommendation for patients all the time. So it's not like a really earth shattering case. It was just sort of interesting. It was something that, again, when I tried to sign this guy out to the ICU, they're like, what did you do? And why did you do that? It was kind of weird. You intubated him, even though he's like comfort focused. That's sort of weird. So it became kind of a discussion. And eventually I understood where I was coming from on the case. But anyway, and I will say that, you're absolutely right, Chris. I think there was another case I was thinking about presenting of a guy who had come in essentially estranged from his family members. And I was in the ICU at the time, and sharing my worries about the patient and what my expected trajectory was up front and not candy coating it really did inform the more palliative aspects of his admission to the ICU over the next week. And I think priming, and setting up palliative care discussions can be a really important role as an acute care provider in the emergency department, or even as an outpatient provider. Sometimes that role can be filled. So I think you're absolutely right. Yeah, Linda.
Yeah, I just wanted to congratulate you because I am ER trained also from LA, but I graduated in 1980. So, but just bringing this conversation into the reality of the day-to-day life, I've watched the evolution being a hospice medical director and being in palliative care. So, when I first was a medical director, I would try to do a lot of procedures in the home. And
Hmm.
you could do that if you train the hospice team or you were a hospice medical director who could do it. But then liability became such an issue that
Hmm.
people backed off from it. But I mean, there's lots of ways to go around achieving symptom relief. And I've been amazed at how qualified the hospice nurses are and what they're willing to do. So that's another avenue to kind of think through, and every agency has to kind of jump through those hoops and do the training. But if you have an EM trained person as your director or involved with your team, there's a lot of additional training that can go on to alleviate symptoms in the home. So anyway, I'm excited that you're doing what you're doing. Been
Well,
watching
thanks.
for 30 years.
Yeah, and I know it's complex. I know that everybody has the regulatory limits, but I
Mhm.
frankly wouldn't have a problem taking a paracentesis set to someone's home,
Mhm.
and doing a paracentesis in someone's home on hospice.
Yeah.
But that's all I need is an ultrasound, which is now portable, and a paracentesis kit. So, I just it's just food for thought. I mean, I think we could give pain medications for dyspnea and abdominal pain, or we can just change what the physiology is, which is pretty
Right.
easy to do. But that's just my perspective.
Yes.
Just noting the time, and I think a lot of people are leaving, but please make sure you click on the link to give Rick feedback. It's in the chat. Rick, this was amazing. You brought up so many different areas of food for thought for all of us. And I wish too we could have had more time to discussion. There's so much
Yeah,
rich
sorry about that.
information here. No, that's great. You did a great job staying cool and calm. And also, what a delight how many EM palliative care people are in the audience right now
Yeah.
too. So wonderful.
Okay. Thank you, everyone.
Thanks, everyone.